Hello and welcome. I am Kim Nitz, a Community Program Manager for the Parkinson's Foundation. We are passionate about helping every person with Parkinson's to live better, so it's great to be reaching so many of you today in this virtual meeting format. We've got participants from all over the states of Missouri, Kansas, and beyond, and we welcome you all. Today's program will focus on some of those less often discussed non-motor symptoms of Parkinson's. And we do appreciate the feedback we've already received from you about the importance of this topic. The Parkinson's Foundation is here to support the estimated 1 million Americans living with Parkinson's disease, as well as the many who care for them and those working to end the disease. For those of you new to the foundation, we focus on 3 goals: advancing Parkinson's research, improving care for those living with Parkinson's, and empowering the Parkinson's community with educational resources. These resources are extensive and include our website, parkinson.org, our free educational book series that you can download or order in hard copy. They look like this. A library of recorded podcasts and webinars, and our hospital safety kit called the Aware and Care Kit, if you're not familiar with that. Another great resource, if you have not connected with them yet, is our national helpline at 1-800-4PD-INFO, which is staffed by Parkinson's specialists ready to assist. And additionally, we have a set of newly diagnosed resources, which is a great starting point for those who've recently begun their Parkinson's journey. You can contact our helpline for further information on that. Across the country, the Parkinson's Foundation brings the community together for Moving Day, a walk for Parkinson's, which is a national fundraiser to support Parkinson's research and local wellness programs. On May 1st, we will be hosting Moving Day Kansas City and welcome all of you to get your team registered now. The walk this year will feature a car parade to engage the community and bring awareness to PD in a safe and contactless way, while raising funds to support programs, resources, and research. We are also proud to offer PD Generation, a national research initiative that provides genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost in English and Spanish. The goal of PD Gene is to leverage genetics as a powerful tool to help us uncover what is responsible for slowing or stopping the progression of Parkinson's. Learn more and enroll at parkinson.org/PDGeneration or call our helpline. As we all continue learning and engaging from home, we are offering a series of online programs each and every week, including Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. We have some great programs coming up on topics like cognition, art, brain games. So we hope to see you at one soon by signing up at parkinson.org/PDHealth. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made that programming possible. And before we get started, I'd like to thank today's silver sponsors: AbbVie, Acadia, Accorda, Boston Scientific, Kyowa Kirin, Medtronic, and Synovian. Their support does help keep today's program and many others free and available to our Parkinson's community. You can find educational materials about these companies by visiting our virtual exhibit hall located at the link you see on your screen and in the chat. So now I'd like to introduce our featured speaker, Dr. Susan Cyphers. Dr. Cyphers is a movement disorder specialist at St. Luke's Marion Block Neuroscience Institute. She received her bachelor's degree at WashU in St. Louis, her master's degree in neuroscience at the University of Southern California, and her medical degree from the University of Kansas. She completed her internship and neurology residency at the University of California, Irvine. She then completed her fellowship in movement disorders at Stanford University before joining St. Luke's in 2014. Dr. Cyphers' clinical interest is in treating patients with movement disorders, including Parkinson's disease, with a particular interest in DBS programming. I'll remind our audience you can submit questions during the program at any time via the Q&A icon. And now I'll turn it over to Dr. Cyphers.
Just a moment here. Let's see. Okay. Thank you for having me today. It's a pleasure to speak to you today about this topic. It's always more fun to speak to an audience of people rather than my computer screen, but it can be nice to listen at home. So what we're going to do today is talk about people diagnosed with Parkinson's and their loved ones to help them understand aspects of living with Parkinson's disease that are not easily discussed, find strategies to treat and cope with these challenges, and learn how to improve communication. So our objectives today are to learn about the impact of psychosis, impulse control disorder, and other less frequently discussed symptoms in people with Parkinson's, the role medications play in these conditions, and learning techniques to improve communication about such sensitive topics with both medical providers and loved ones. To understand treatment options and practical strategies for coping with these challenges in daily living. These are my disclosures. So we're going to talk about some, fairly heavy topics today. And I want to do a reminder to everyone that Parkinson's disease is a very different disease for different people. Not every patient has the same symptoms, both motor and non-motor, and even when present, the severity varies. So the topics today are to raise awareness and open communication, but it's important to know that not everybody will experience everything, and it's important to know that we do have treatments available. The medications will be mentioned, but it's not the focus of the talk. You should get a copy of the slides if you want to refer back to any details. But I'm mainly going to talk about non-medication treatments, coping, how to talk about it, and what resources you have. Some of the slides in the beginning, like this one, have a little piece of artwork from the art therapy class that we are sponsoring. So they are done by Parkinson's patients, which is just kind of fun. It's a nice opportunity that we'll talk about a little bit more at the end. So the first thing, this is the exception, but the first thing I want to talk about today is impulse control disorders. So what is this? This is doing things excessively. So compulsive gambling, buying, hypersexual behaviors, excessive eating. It occurs in up to 14 to 20% of Parkinson's patients over the course of their illness, but it's usually mild and not problematic. The thing to really remember about this is that it most often is seen in the setting of dopamine agonist medications. So those are pramipexole, ropinirole, rotigotine, apomorphine. And since we've started educating people about the possibility of this occurring, we catch it much earlier. So it starts off very, very subtle, small changes. And if it's recognized by the patient, and it's also very important for caregivers to know about this because sometimes the patients themselves don't recognize it, it can be addressed before it becomes problematic. But before we were really good about this education, when people didn't know it was from these medications, it would sometimes get out of control. I remember there was a patient in my training who, even though he had lived, a very steady life, he'd been married for 50 years, he suddenly went out and got a prostitute and gave her his entire life savings. She fled to Mexico and his wife divorced him. I have another patient who spent $75,000 on an internet psychic. So this is an important topic to know about, but it's not a topic that you need to worry about. If you see the subtle signs, just bring it up with your provider. The treatment is removing the offending agent. Again, usually the dopamine agonist. Most of the time that is sufficient. It is important not to suddenly stop the medication because it needs to be weaned slowly. So just discuss it with your provider. There are other options like cognitive behavioral therapy. When people have OCD outside of a Parkinson's setting, medications like Zoloft, sertraline can be helpful, but there's not good evidence in this scenario, and most of the time we just don't need it. There are a couple of related disorders that I wanted to mention today. One is something called punding, which is stereotyped, repetitive, purposeless behaviors. So people often will do things that are a throwback to the job that they had. So for an example, there was a famous story about a patient who was a banker, and he would get up in the middle of the night and plug in numbers on an Excel sheet. Not for any purpose, they didn't add up, they didn't do anything. It was just this purposeless, repetitive behavior. Another one is dopamine dysregulation syndrome. So this is one to keep in mind. This is compulsive medication overuse. And whereas what I discussed before is most common with the dopamine agonist, this is actually most common with the short-acting, higher potency dopamine, such as levodopa. So this is taking more than you're supposed to take. I'm going to talk in a few minutes about anxiety. Now, anxiety is something that can happen baseline, but it's also something that can happen as a wearing off phenomenon. When we talk about wearing off from levodopa, we often think of motor symptoms. You know, you take the medication, your tremor's better, you're walking better. And then when the medication starts to wear off, these motor features come back. But sometimes the wearing off is non-motor features, and one of these is anxiety. And that's important to differentiate. Sometimes what happens is we adjust the dopaminergic medication and we can treat it that way. But sometimes that is a powerful feeling and people start treating themselves and taking too much dopamine, which can really be problematic. Hobbyism is just something else to know about. You can have compulsive internet use, artistic endeavors, writing. Okay, so the next thing we're going to talk about is mood disorders. These are very common in Parkinson's disease. This is, sadness, crying, decreased enjoyment, worry, feeling guilty or worthless, decreased concentration, irritability, agitation. But recognition is key because there are treatments available for these. So first we'll talk about depression. This is very common in Parkinson's disease, and it can happen very commonly in people that had no predisposition to this before. And about 50 to 75% of Parkinson's patients experience depression. It can be associated with higher daily doses of levodopa, the presence of mild cognitive impairment and hallucinations, and it often goes hand in hand with anxiety. There are medications to treat it, but there's also non-medication options. One of them is cognitive behavioral therapy. And this is something I'm going to come back to at the end. I think it's an underutilized option. Symptom severity for depression improved by 56% with this therapy, so it's very effective. Other things to keep in mind are exercise and sleep. These are very important aspects in many components of the disease, but depression is one of them. Pseudobulbar affect is the words that are used to describe this inappropriate laughing or crying. So sometimes out of the blue, breaking into tears at a commercial that's not even sad, or laughing at something that isn't funny. There is a medication that can be used to treat this, but most of the time, just recognizing that this is an aspect of the disease is enough for people to say, okay, that's why he's doing this. Most of the time, it's not bothersome enough to start a daily medication, but there's one available if it is. Anxiety. So I mentioned this before, that it can be a wearing off phenomenon. It can also be just at baseline. There's several medications to treat it. The SSRIs, which is the class of medicines like sertraline, Zoloft, are the best for maintenance type therapy. You can use medications like buspirone, but you have to be quite careful about benzodiazepines. So this is Xanax, alprazolam, Valium, diazepam, clonazepam. These medications in this setting can cause confusion, sleepiness, and imbalance, things that can already be problems. I really try to avoid this class of medication. Sometimes use a low-dose clonazepam at night for REM behavior disorder, but when we're treating anxiety, we try to use the other options. Apathy. This is something that is often confused with depression. So what does this mean? This is lack of motivation, just not wanting to do things. It's thought to be from the disrupted effort-based decision-making in Parkinson's disease. and it can be difficult to treat. But the importance of differentiating it is sometimes family members will say, she's depressed. And she says, no, I'm not. I'm not sad. I'm not tearful. I'm happy. Well, why don't you do more? Well, I just don't really want to anymore. And so that's an important differentiation. There are medications, again, that can be helpful if it is problematic. So this was a paper that looked at cognitive behavioral therapy for depression and anxiety in Parkinson's disease. And the thing to point out is that Parkinson's patients with depression have faster cognitive and motor decline, poorer quality of life, and increased mortality compared to non-depressed Parkinson's patients. And the similar outcome in terms of anxiety. So it's very important to recognize these features and to treat them. Okay, so the next topic we're going to talk about is Parkinson's disease dementia. This is different than other types of dementia like Alzheimer's disease. The incident rate is increased 4 to 6 times compared to controls. And the risk factors are older age, more severe Parkinsonism, in particular an axial presentation. So stiffness, postural instability, gait disturbance. So when there's a lot more problems with the walking and the balance, and mild cognitive impairment at baseline. This was a famous study looking at 20-year outcomes in terms of dementia. And the graph is a little bit difficult to see at first glance, but what it's showing is dementia-free survival over time, stratified by age of onset. So the onset of Parkinson's-associated dementia is around 70 years of age, regardless of the age when the diagnosis of PD was made. So the earlier the onset of Parkinson's disease, the longer the survival prior to dementia onset. What is the cognitive profile in Parkinson's? So it's a slowly progressive course of cognitive impairments in attention, executive and visuospatial function, as well as memory, with relatively preserved core language functions. That's a lot of big words, and I'm going to break down what all of those mean in a minute. But the point is to say that it's a different profile. It has more of these dysexecutive features compared to Alzheimer's disease, which is very prominent memory difficulty. Also, hallucinations, delusions, apathy, and mood changes are frequently associated behavioral features. They'll pop up on my screen here. So, these are the 5 main things that are involved in Parkinson's related cognitive change: executive function, visuospatial function, memory, language, attention, and working memory. So what are these? Memory. There's actually 3 parts that we think of in terms of memory: encoding, which is forming the memory and storing it; maintenance, that's self-explanatory; and then retrieval, accessing the memory. So Parkinson's is more of a problem with retrieval, whereas Alzheimer's disease is more of a problem with encoding. So as an example, if I asked a patient with Parkinson's and Alzheimer's, I'm going to give you 3 words, and I want you to remember what those are. I'm going to ask you in a minute. A few minutes later, you ask, it may be that neither of them can remember the 3 words, but if I ask the Parkinson's patient and I say, okay, I'm going to give you a hint, it was a color, they say red, because they stored the memory. It was there. They just had trouble accessing it. So if I give them a cue, sometimes they can pull it back out. Whereas you say it's a color to the Alzheimer's patient and they look at you like, I have no idea. They can guess randomly, but they never stored the memory. It's not there. No amount of cues is going to help them find it. Attention and working memory. So the classic example of this is a friend gives you a 10-digit phone number and you keep it in your mind for about 30 seconds while you look for a pen and paper. This type of thing becomes more difficult with Parkinsonian change. Visuospatial function. So this is seeing things in the environment and understanding the physical relationships between them. So an example is, we test this in the clinic, we draw 2 interlocking pentagons and we say, copy this. And that can be very difficult for a Parkinson's patient to do, even very early on in the disease. And where this has the most functional impact is driving. So if somebody misses a parking spot, they go over the lines, they're clipping the corners, they're not seeing this space in the same way. They have problems with directions somewhere that is not familiar. These are concerning signs about driving. And one of the reasons I bring this up is because it can happen far before any more obvious memory or other cognitive changes. So it's very important to keep an eye on this. And this type of dysfunction is thought to be one of the causes or makes people more prone to hallucinations. Executive function. So this is, outside of driving, I think this is the one that has the most functional impact. So what does that mean? That means planning and organizing, complex or novel problem solving, shifting attention, keeping track of or alternating from one task to another, not being susceptible to distractions, generating fluent speech of thought or words, and learning the rules of a new task without direction or explicit cueing. Language. So word and sentence generation. So the most common thing is names of objects and people. It's on the tip of the tongue, this word finding difficulty. Oh, I just can't think of the word. And a lot of times if you give them enough time, they'll come up with it. Again, it's there, but retrieving it is a little bit more difficult. It's uncommon in Parkinson's to have a more primary severe language dysfunction like an aphasia. So this was, again, this famous study looking at Parkinson's disease 15 years into the diagnosis. At that point, cognitive decline was at 84%, and 48% of which fulfilled the criteria for dementia. The other things we're not going to talk about today, but it points out that at that stage of disease, the symptoms that are problematic are the ones that are generally not responsive to levodopa. And this looking at, dementia at 20 years, the pullout from this is dementia and psychosis were a key factor leading to nursing home placement, and depression is the most significant predictor of quality of life. So treatments. There's actually good evidence for rivastigmine or Exelon and donepezil, Aricept. They both have a high level of evidence, but the degree of improvement is modest. Unfortunately, that's the case for all forms of dementia. We don't have great medications for this. Namenda, or memantine, is a medication that's more commonly used in Alzheimer's disease. It's occasionally tried in Parkinson's, but there really isn't much evidence to support that. Okay, so Parkinson's-associated psychosis. Two forms, hallucinations and delusions. So what are they? Hallucinations are most often visual, so seeing things that are not there, but it can be others. It can be auditory, hearing things, touch, taste, smell. In terms of the visual hallucination, seeing people and animals is most common in Parkinson's. Delusions is a belief in something not real. It's most often paranoid beliefs of infidelity or abandonment that involve spouses or other caregivers. Psychosis occurs because of the disease itself and the medications used to treat the disease. Why it happens is not completely clear, but it's thought to in part involve the visuospatial processing difficulty, sleep dysfunction, and neurochemical changes like the dopamine dysregulation. This is a symptom that is very important when we're thinking about it, to think about degree, okay? And I'm going to come back to this in a minute when we're deciding how to treat or if to treat. But the psychosis is something that can be very intense to the person experiencing it. And sometimes logic in trying to understand it doesn't work. And I'm going to tell you an example of a story just to provide some perspective about this. I have a patient who is very convinced when she came to me that there was something in her nose. It was in the septum between the nose, and it was an object. And she had very little cognitive decline. She was very with it. But this was a firm belief that she held. And the object would change. I remember one time it was a worm, but she came in one day and she said that it was a pair of tweezers. I thought I misunderstood her. And I said, did you say a pair of tweezers? She said, yes, there's a pair of tweezers that is stuck in my nose. And I said, okay, can you show me with your hand, how big is a pair of tweezers? And she went like this. The intriguing part about that, if you can't see me on the camera, is she put up her fingers to the appropriate length of a pair of tweezers. Some part of her brain looked at that and said, well, that's not right. That can't fit in there, and shrunk it down to be very small. And then she looked back at me and said, this fits. And no part of that was a recognition that she was modifying it. It just was, that was her brain's explanation to herself, and it was a very convincing thing. So what are the risk factors for this? The Parkinson's medications can contribute to it, also other polypharmacy. And a comment about that. So when people have a neurodegenerative disease, it changes the reserve, okay? So as an example, a medication that may have been very well tolerated before may no longer be as well tolerated. It's also similar to things like getting a urinary tract infection. When there isn't the same reserve to deal with that, it can become very profound. People can have prominent hallucinations or delusions just because of a urinary tract infection. Increasing severity and duration of the disease increases the chance of this. Increasing severity of cognitive dysfunction, depression, anxiety, older age, daytime fatigue, and visual impairment. It is a strong predictor of caregiver burden associated with diminished quality of life, nursing home placement, worsening patient outcomes, and increased mortality. In reviewing Medicare claims, there's some interesting numbers to point to the evidence for this. So 75% of patients with PDP spent time in a long-term care facility and for an average of 179 days, whereas 55% of patients without PDP did for an average of 83 days. And the annual all-cause reimbursement, so the cost of care of all components for these patients, was far higher in patients that had the psychosis versus PD patients that did not. So treatment, okay. If there is sudden onset or sudden worsening, the first thing to think of is there something medical underlying? Again, a UTI can bring this out very easily. When it's from the disease itself, it tends to be a much slower progression. But again, acute worsening is something where you have to look back at that. And then it becomes looking at the medications. So you're looking at, the non-PD medications, pain medications, including narcotics, again, benzodiazepines, anticholinergic medications. And again, we're talking about this reserve. So your primary care or your urologist may say, well, that bladder medication couldn't be the cause, but it actually could in this scenario. So it's very important to keep all of these things in mind. And then when it comes to even the Parkinson's medications, they're not all equal. So amantadine followed by the dopamine agonists are the most likely to cause hallucinations. And both of them are far more likely compared to the other medications. So when you're on all three of these, you're going to want to be shifting to more levodopa. Now, levodopa can as well, and higher doses make that more likely. But in terms of the relative chance of it occurring. So I said degree was important, okay? So these often start as non-formed hallucinations, so kind of seeing something vague in the background. Then they become formed. And again, most often people and animals, but they have retained insight. Somebody may say, well, I see a person there, but I know it's not real, and that doesn't bother me. I just look away. Then they can start to lose insight. But the first step is often being able to be redirected by a caregiver. And then it can progress to losing insight and becoming distressing, and it may affect behavior. But again, it's important to talk about the degree and what's happening. So As an example, I had a woman come in with her daughter who was very caring. And the daughter says, you know, she's having these hallucinations. I really think we need to start a medication for them. And the patient herself looks at me and she says, don't you dare take my friends away from me. Sometimes it's not bad. Sometimes patients see things that they actually enjoy. And even when that occurs, it's important to understand, is it changing behavior? So if Doris is standing at the window looking out in the yard and she sees a bunch of kids playing, and that makes her smile and she thinks that's nice and it's, you know, not causing any harm, then that's something that we can allow to happen. But if she goes out into the street and you go running outside and as a car is approaching and say, what are you doing? And she says, well, can you believe it? That truck was going to hit these cute little kids playing in the driveway. So now she's putting herself at risk. She doesn't recognize they're not real. It changed behavior. And that's a difference that you have to be more aggressive about. So in treating it, you'll have to balance the motor symptoms and the cognition psychosis component. So again, you look at the medications. Sometimes you have to allow some motor symptoms to come out a little bit if it's going to help treat this. And other times we need to consider antipsychotic medication. So the only one that's been FDA approved for PD psychosis is pimavanserin. The other two that are acceptable to use are quetiapine and clozapine. The other antipsychotics you want to avoid because they block dopamine and they can worsen the motor features of Parkinson's. Clozapine has a little bit better evidence, but it's rarely used. It requires blood monitoring. Providers have to be part of a registry to even prescribe it. So it's much more common to have quetiapine or Seroquel used as a backup. You can consider the medications like rivastigmine and donepezil. If you haven't already started those can maybe have a little bit of benefit, but they're not as direct as using these others. Oh, one more thing about this. So there are risks associated with this class of medication in this population, but it's also important to have perspective. One time I got a page late at night from a wife who was in a panic because her husband was running around the house saying that intruders were trying to get in and was looking for weapons. And she says, what do I do? And I said, well, we had just started the medication for this. You know, is it not working? And she said, oh, it worked great. The hallucinations were gone, but we stopped it 2 weeks ago. And I said, well, why? And she said, well, our primary care physician told us to stop it because there were risks associated with this medication. And I say to her, okay, but there's a much greater risk to him running around the house looking for weapons. So there has to be a perspective on this type of medication usage. Okay, so another kind of heavy topic, but an important one is end-of-life planning. So a couple years ago or last year at the International Congress, there was a speaker that came and talked about this issue in Parkinson's patients. And these were some kind of interesting numbers, I think. 80% want to talk to their doctor about end-of-life planning, but only 7% have. 82% want to have it in writing, 23% have. Most want to die at home, but most die in a hospital, about 70% for each. Most don't want to burden families with decisions, but most don't tell them what they want. Living in a hospital with dementia has a 1-year mortality of 55%. 70% of older adults dying in a hospital lack decisional capacity at the end of life. Proxies are more likely to choose more intervention compared to patients themselves. When patients discuss with lawyers, they choose more intervention compared to when they talk to their doctors. The readability of advanced directives is often too difficult to interpret for the average educational level. So patients with advanced PD should have an advanced directive and a power of attorney. ideally should be repeated yearly. But if you remember the stat on the previous slide, I would say at least doing it once is the goal. This next number, I think, is a very important number. 65% of advanced PD caregivers receive physical aggression. 27% receive sexual aggression. That's something I'm going to come back to a little bit later. So, how do you talk about it? How do you talk to your doctor? How do you talk to each other? And what are your resources? So this may seem a little bit odd to bring this up, but I think it provides perspective and it's going to make sense in a minute. So one of the challenges of modern medicine is the expanding information and treatment options, opposing the time constraints of a productivity-based system. So doctors are under pressure to see more patients despite the increase in administrative and electronic health record requirements. The graph on the right is kind of a telling situation. It's the growth of physicians versus administrators over the years. And the little reddish line at the bottom is physicians and yellow is administrators. Medicine has become a lot about business. According to an American Academy of Neurology survey of time neurologists spend with patients, I spend more time than 99% of neurologists, but I still feel rushed to address all patient concerns. So, this is why it's important on your end to prioritize what you want to discuss. Pick the top 3 stated at the beginning of the visit. Have a list so you don't forget. I don't want to spend the majority of an encounter guessing at what might be happening with you when it's not at all what you want to talk about. I want you to tell me in the beginning what it is that's bothering you. If you want to address a complex issue like end of life planning, don't wait until the very end of the visit. So remember, we care. Our priority is to help you. We want to hear about your concerns, the things that affect your quality of life, to make the visits as productive as possible. And don't be embarrassed. We can only help you if we know what's bothering you. And trust me when I say there is nothing we have not heard. While our focus is on the patient, we care about caregivers as well. If you're struggling with behaviors from our loved one's PD, please tell us. Many of these sensitive topics are actually not recognized by the patient experiencing them, so we rely on caregivers to tell us. And I want everyone to remember, patients and caregivers alike, that while Parkinson's is a frustrating neurodegenerative disorder with many faces, I actually picked this because it is also the one with the best treatment options. There's a lot we can do to help, but we can only treat what we know about. So speak up. It's also very important to talk to each other. One of the things that I think is very nice about working in the Parkinson's population is there tends to be steady relationships, strong caregiver support, but it's a joint effort and it starts with communication at home. One of the things I don't like is when a caregiver tries to slide me something on the slide. Say, I don't want to say this in front of him, but this is what's going on. He's having paranoia, delusions, but they won't say it in the room. The problem with that is twofold. One, I can't really treat that if I'm not allowed to speak about it to understand it. And two is that it drives some distrust. Okay, so here's an example. Judy tells me that Bob is paranoid and doing all of these things. He needs to be on a medication. I say to Bob, hey, I think we should maybe think about this type of treatment. Well, what's it for? It's for hallucinations and delusions. Well, I'm not having that. And he looks at Judy, what did you say? It builds a distrust. And that's not going to help us moving forward. It's not going to help you at home. It's not going to help us with the medical treatment. So you have to be open about it. But there's two ways of talking to each other, the patient perspective and the caregiver perspective. Patients need to share their experiences, but they also need to recognize how the disease affects caregivers. It changes their life as well. As a patient, you need to share your feelings and be proactive in your treatment. And one of the things I like to say is do not let the disease define you. Yes, it's hard. Yes, there are a lot of different ways in which it affects you. But you can't make it define you. You have to find the other things, the ways around it, and the other things that bring you joy. And remember that caregiver fatigue is a real thing. So keep in mind that dynamic. And caregivers need to recognize the depth of symptoms and how to help. Talk to your loved one, make them feel comfortable sharing their experiences. There's nothing more awkward than my asking very casually to a patient, oh, are you having any hallucinations? Patient says, oh, yes, I see snakes every day in the bathroom and I try to avoid the closet because there's a scary man in there. And the wife looks at him and says, what? You never told me this. And he says, well, you never asked. So sometimes things don't come up unless you talk about these types of experiences. And participate in the visits, okay? So think about what you want to address. Talk to your loved one. And if they're having trouble expressing that in the visit, help them out so that you can both leave with the best outcome. So for the sake of time, I am going to skip this part about coping styles. You can look back at it in the notes. I'm just going to mention a couple of things. So wish for information was something that was very important when looking at Parkinson's patients and coping styles. And it was steady throughout the course of the disease. So it's important to, to follow that and to do these types of things to learn about the disease. Social support is extremely important, okay? So family, friends, people in the workplace, peers, and doing activities, socializing, and helping people be successful with exercise, which is such an important component of the disease. It slows progression of the disease. It helps with motor and non-motor symptoms, and it often allows for lower doses of medication to be used. It's also very important from a caregiver perspective to understand the neuropsychiatric symptoms, because not understanding them can make you see the person as unwilling to help themselves. And that can cause a strain on the relationship. So understanding, the increased burden of care and low understanding of disease by the caregiver. So what are your resources? Well, things like this that talk about other aspects of the disease, Parkinson's support groups, nonprofit organizations, psychologists. Our social worker, for example, is trained in cognitive behavioral therapy, stress reduction, mindfulness. Also can help couples navigate through difficult times when the communication is struggling. So what is cognitive behavioral therapy? It is an education and therapy that can help treat the depression and anxiety in Parkinson's. It can also help with other things like sleep. People can learn to recognize and change maladaptive thinking processes and help gain control over thoughts that negatively affect their emotions and behaviors. This is kind of a complicated breakdown of all the different ways in which ways of looking at the disease can affect outcome. But again, you can kind of review that later if you're interested. Here's an example of a one-to-one intervention. So anxiety management and relaxation, breathing exercises, progressive muscle relaxation, guided imagery, cognitive interventions, sleep interventions. Every year we have a talk from a sleep specialist who says, sleep hygiene is just, if not more effective than any of the sleep medications on the market. It's very important. Seems basic, but a lot of people don't do it. So using the bed for sleep only, relaxing before bedtime, doing things like reading in another room, keeping regular sleep hours, limiting excessive time in bed, naps, caffeine, alcohol in the evening. And then the structured cognitive behavioral therapy can also help with the sleep. Another aspect of it is examine the evidence. So here's an example. You have a situation, freezing in the bathroom. The automatic thought is, I'm helpless. Evidence for, I was alone in the bathroom in the middle of the night and unable to move. Evidence against. This happens quite a bit, so I planned in advance. I had my cell phone in my pocket. I called my wife on the house phone and she helped me back to bed. Rational response. Even though I was physically unable to move my feet, I was able to help myself out of the situation, and thus I am not helpless. One of the techniques that is used is called behavioral experiments. So this is an example, the negative thought or prediction. It will be impossible to have dinner at a restaurant because of my tremor. The experiment is, I will go to the restaurant with my spouse on Saturday at 6 p.m. And the outcome was, hey, I was able to eat dinner. I ordered food that did not need to be cut. I requested a straw and lid for my drink, and I enjoyed getting out of the house. There were no leftovers to bring home. So one of the other things that we use that we're happy to offer is an art therapy program. So art therapy has been shown to help with hand dexterity, mood, self-expression, as well as enhanced quality of life. We have a program that is led by a certified art therapist who is also a licensed clinical counselor. She is fabulous. She actually just sent me a paper yesterday about the benefits of art therapy for visuospatial functioning in Parkinson's disease. We are holding these sessions on the 5th floor of our Broadway building in the lobby, the first Thursday of the month at 5 p.m. It's currently held, they changed the COVID restrictions on the space, but the plan is to resume in April. And the sign up is on the website. So again, please, we would like, the people who have done it have absolutely loved it, and we would like to expand that further to reach more people. Okay, thank you. I am ready to take your questions.
Fantastic. And we thank you, Dr. Cyphers. I will get right into questions for you. First one is, can you give information about vision problems and a possible relation to cognition challenges?
Yes, so there are actually several changes in the vision associated with Parkinson's disease. Sometimes there is a slight convergence difficulty where the eyes don't line up quite right, and that can result in double vision. If that is occurring, prism glasses can be helpful to bring the images together. There are also changes in color perception and contrast. And so sometimes it can be difficult to see things with different colors or different levels of contrast that can affect things like reading. And, you know, again, when there becomes not so much the vision itself, but more of the visuospatial processing, that can certainly play a role, as I've discussed, with cognition and hallucinations.
Okay. Next, asking for resources on how to navigate these cognitive changes. And this person specifically asked, how do we know when it's time to stop driving?
So that's what I was trying to get at when talking about the visuospatial functioning. So the signs, the warning signs, are often things like missing the parking spot, you know, clipping the corner, going too far over in the lane, getting up too close, or, you know, those judgments on perception. And, you know, one of the things that you can do if you think it's happening, but there's a disagreement about it happening, is you can go through a formal driver's evaluation, can be ordered through occupational therapy, and they can sort of simulate that and help you understand if it's safe. And if you are safe to be driving, then you know you can say, back off, I'm fine, I passed. And if you're not, it's good to know that.
Great. That's related to a question that we had as to whether speech or occupational therapy has a role with regard to cognition and mood.
So yes, you know, the most common ways that we think of speech therapy in Parkinson's is, you know, the LSVT, the voice therapy, learning to project the voice, and when we're doing swallowing assessments. But there are also cognitive aspects to speech therapy that can be helpful. That's out of the physical, occupational, and speech, that's the domain that we think of in terms of the cognitive help.
Okay, so that would mean asking for a referral, asking their neurologist for a referral to speech therapy, if it's indicated. Okay.
Yep.
Great. A question on how do I address the denial of my person with Parkinson's who's minimizing how their symptoms are actually putting them into dangerous situations. They're running into corners. They might be having challenges using a knife during meal prep.
So that's a difficult one. It sort of depends on where the trouble is. If the trouble is on the front of, communication, that's something that working with somebody like a counselor or a social worker can kind of help navigate that. If it has more to do with, the motor difficulty and not recognizing it, again, it's very important to bring that up in visits so that the doctor can emphasize the safety concerns and the things that are important to avoid, like ladders. Don't go on ladders. But oftentimes having the physician reinforce those kinds of things can be helpful. But sometimes that's a tricky aspect of the disease that, again, I would say that the resources to help are really trying to get in with, a social worker or a psychologist to help. That can be, it doesn't have to be for just the patient, that can be for the couple, kind of helping, how do you talk about this, and the cognitive behavioral therapy aspect, again, trying to look at things in a little bit different way. Like this is your perception of this, but this is, an outcome or what can happen from it.
Okay. Somewhat related to that, but on the topic of impulse control, how do we as caregivers know when we may need to seek legal intervention to prevent experiences like the person with Parkinson's giving away money or other behaviors?
Well, so, I think sometimes you have to kind of transition certain things and kind of, or at least have a check in place of, is there spending that's excessive? Is there forgetting to pay bills? Is there evidence of things that are causing problems? And whether that's joint accounts or an outside person to come in and help navigate that. Sometimes you have to have, power of attorney where, children, for example, are managing, kind of helping make decisions in terms of money. I had a case recently that was actually quite interesting because the family the son was very concerned about this, the woman buying things or doing things, and he ended up, taking away the laptop, the iPad, the phone, everything. And she was actually very high functioning cognitively and went through the neuropsychological testing to help understand where this sort of disconnect was. And the result was that, she needed to be given more independence, and she did need to have some access to that. And so if you're having difficulty understanding it, going through formal neuropsychological testing is something that can really help explain what level of difficulty is there. Is it more, because sometimes there's a misinterpretation from family members versus patient. And so that kind of formal assessment can help you understand.
Great suggestion. Also related to impulse control, why do I get snacking urges or do not want to eat at times?
So, again, eating, snacking urges, that can be a manifestation of the impulse control difficulty. A lot of this comes down to this dopamine dysregulation. Over time, the brain loses dopamine, then we're giving dopamine back. And it can be a confusing combination where there's still some problems. You're treating one thing, but you're kind of causing another. And so that's the reason why. Again, some medications are more prone to do that than others. And so you may need to take a look at, what medications you're on. Sometimes it's a dosing issue. And so we have to kind of back that down a little bit. But again, that's a common manifestation, and the importance is the degree.
Switching to the topic of mood, what can we do if we think it's chronic pain that's leading to some of the depression? Is that part of Parkinson's?
It is. Pain is one of the non-motor features of Parkinson's. It is an important thing to recognize. Sometimes the pain is from the stiffness, for example, and sometimes we're having, if we, change the medications, we can improve the discomfort level that wasn't recognized. But, common things are common. Sometimes there's, degenerative changes in the spine, there's arthritis. And so it's important to discuss the type of pain so that your doctor can help you understand what the cause is and how best to treat it.
What about, are mood changes ever related to off time?
Did you say mood?
Mood, yes,
Yeah.
related to off time.
Absolutely. So that's what I was saying is that the anxiety can be a non-motor off. Okay. And that's very important to distinguish because we sort of address it differently. So you really want to look at time of day, I'm really anxious right now. Am I due for my medication? Did I just take it? And see if there's a correlation. Because it doesn't always fit with observable motor off. Sometimes you're not really seeing a difference in motor function, but that actually correlates with timing, take the medication, and suddenly that gets better. So that's one of the first steps in assessing mood, especially anxiety. That's where we see it the most.
Okay. Regarding cognitive behavioral therapy, is that something my neurologist can refer me to, and is it covered by Medicare?
Yes, so there's different people that do it, okay? And actually, I have to say, this was one of my frustrations when I started here, is that I had a heck of a time finding a psychologist who would do cognitive behavioral therapy for adults without it costing a ton of money. Because it is difficult to get it covered. Sometimes it's covered very well, sometimes it's not. So I actually talked to our social worker and had him get trained. So he got trained and now can do it for any patient in our system. And that's just part of, the treatment of being in the group. So because he does it, I've lost a little bit of touch in terms of other resources around the city since I first was going through that.
But it is something you as the neurologist can make the referral for CBT.
Yes. You actually don't need a referral, to be honest. So, you can see a psychologist without a referral usually. Sometimes they'll request one, and obviously your neurologist can give it. But you can look into them. I know there's others around the city that do it. I don't know if there's a resource through the National Parkinson's Foundation website for that.
Yeah, actually, our national helpline is a good resource for getting connected to somebody trained in CBT. There was also a question about your art therapy program. Do I need to be a St. Luke's patient to participate in that?
No, it is open to anyone in the metropolitan area. We would love to have, more people come to that.
Excellent.
You need to sign up in advance. So just go to our website and you can sign up. They won't ask you where you're treated. Doesn't matter.
And that's a good time to remind everyone, we will be sending out links following the program to the art therapy classes as well as other resources. Continuing with our questions, how does a caregiver know when hallucinations have become dangerous and when to take, a different kind of action, or when the caregiver thinks they may not be able to handle it alone anymore?
Right. So this is where really talking through about what they're experiencing and watching the behaviors is so important, because, sometimes seeing things or experiencing things is not distressing. And a lot of times, Parkinson's patients will have these going on and they're okay with it and they don't need a change to address it. When it is distressing, and that's the first question to ask, do these frighten you? You know, does it make you feel uncomfortable? And I had one, you know, as an example, last week, I had somebody say to me, well, you know, there's always these people in the living room. And I said, well, do they bother you? And he goes, no, I like them, but he had this sort of hesitation to it. And I said, well, what's wrong? And he goes, they never respond to me. I talk to them all the time and they never talk back. And so it's sort of going into the kind of depth of how that affects them. And, you know, if it's ever to the point that you're concerned about behavior, if there's acting things out, that's the line where you know, need to get it treated, because that's where you're going to run into problems.
Okay. A couple of questions around end of life planning. What resources are available to get started? Do I ask my neurologist? Do I seek palliative care? How do I get started with this?
I usually refer people to our social worker to kind of help them go through it. Again, it comes back to that sort of readability issue of trying to kind of understand it and understanding resources. You know, some people will have a lawyer, financial planner, those kinds of things, but, you know, there are resources, you know, within your doctor's office. If you ask about it, I think people are probably set up differently. Does NPF have a resource for that?
We do. We do. Again, our helpline has a number of resources on palliative care. So we encourage you to call the Parkinson's Foundation helpline too. Switching back to a question about whether the interaction between carbidopa, levodopa, and protein can affect mood and cognition. So this person says that they've gotten conflicting information about protein and their meds.
Yeah, so protein interferes with the absorption of levodopa. It's not harmful, it's just the levodopa won't work as well, okay? So it's just a timing issue around it. So I generally say 30 minutes before or 1 hour after protein is your optimal, you know, avoidance time in terms of absorption for the levodopa. So, you know, again, sometimes people have a complicated schedule with dosing through the day, and that can be a little bit more complicated to try to avoid the protein. But in terms of, you know, the mood and everything, again, that would be an indirect way, yes, but again, by affecting the, you know, the wearing off, the effectiveness of the medication and the wearing off before the next dose of the medication.
Okay. A question on, can you reverse these cognitive issues, such as with brain stimulating activities or exercise, or only treat the side effects as they occur?
So certainly things can be tried. There's, you know, trials, evidence showing things like Sudoku or whatever can, you know, different ways of doing that kind of cognitive exercise can help. One of the things that I say is find something that's interesting, okay? Because what you don't want to do is do an activity that's stressful. Stress is counterproductive. Stress is negative in terms of cognition. So if somebody's trying to do a crossword puzzle and they can never come up with a word and they're frustrated and they're stressed about it and then they throw it away, I mean, that's not something that's going to help. So there is a little bit of a challenge of finding the right thing, you know, getting involved, getting engaged, similar to social interactions. It's been particularly difficult this last year with COVID. But social interactions, family, friends, you know, even if it's via Zoom, you know, it's better than nothing. Those kinds of things can be helpful.
Yeah, I also want to mention again our PD Health at Home programs with Mindfulness Mondays. Every Monday you can join others with Parkinson's in a great mindfulness exercise. And Fitness Fridays, I know Dr. Cyphers is a huge exercise advocate. So there's some really great Parkinson's specific exercise videos that take place each Friday and are archived out on our website.
Yeah, and there's several facilities, you know, places around the city that, you know, are still offering Zoom classes, like the boxing Zoom classes. You know, I hear that, you know, they're not as fun as doing it in person, obviously, but it's something, and it's a structured activity that can be helpful.
I do have a couple of questions here that just, if we have a couple of minutes, not quite on the topics of today, but somebody asking, they think their partner's smell is being affected, that they smell something like cigarette smoke. Is that part of Parkinson's?
It can be. So again, back to hallucinations, right? So things that are not there. And most often it's visual, but not always. It can be smell. It can be touch. I have somebody who's constantly thinks that there's something in his hand and he's trying to get it out all the time and there's nothing there. So it can have these other manifestations.
Okay. And Dr. Cybers, I think that is it as far as our questions related to the topics today. I know that a number of folks had topics or questions related to a variety of other things, and we encourage you to ask those to our national helpline as well as to your provider if appropriate. So I just wanted to see, Dr. Cybers, if you had any other closing thoughts to share with us.
Yeah, so I wanted to share a little story, okay? So about me and my kids, but hopefully providing us a tad bit of comic relief to a very heavy topic and perhaps some perspective. So there are two parts of neurology, neuroscience that have driven me to study this as a career. And on the one end is neurodegenerative diseases. So when the brain starts losing its ability. And the other end is neurodevelopment. I actually went to graduate school studying neurodevelopment and watching the brain as it is learning going up. And there are some parallels to parenting and watching children on this end of the spectrum. So, you know, we think of it, the classic thing is balance. You know, you watch your toddler learning to walk and, you know, they look like the postural instability that they're about to fall that we commonly see in Parkinson's, but also from a cognitive and behavioral aspect. So, you know, as a child, they're learning how to see themselves as independent, how to assert themselves, but they don't have a great understanding with how that affects other people around them. And there's also something called perseveration. This is very common in dementia, and it's this repeated fixation on something that's very hard to break out of, even with the best of logic. And so last week, I was helping my daughter at night, who's 5, and I had this moment that was a similar experience. And we're picking out her clothes for the next day. She's got a fantastic outfit. Wouldn't have been what I chose, but I was good with it. And I said, okay, what underwear are you going to wear? And she holds up a pair and she says, this one. And I said, well, you can't wear that. That's dirty. She says, but it's my favorite. And I said, I know, I understand. We'll wash it. You can wear it the next time, but you can't wear it tomorrow. But it's my favorite. 10 rounds of this going on and trying to explain, you know, that's not going to be okay for the next day. So I walk out of the room and I say to myself, I was calm, I was logical, and I talked on her level. And she still screamed at me and threw her dirty underwear in my face. But despite the similarity, there are differences, right? I was able to take a couple deep breaths. I walk back in. She's lying in bed. She's as cute as can be. I go in and cuddle with her and all is forgotten, okay? So there's differences despite the similarities. And it had me thinking, okay? So most people have been through this experience. They can kind of relate to that, raising kids. But why is it that it's kind of easier to deal with that on some levels? So one is, we expect it from kids. We don't expect it from adults, okay? We signed up for it. We didn't. I mean, technically, when you say in sickness and in health, maybe you did, but in a different way, right? And with children, we know that if we take the time to get them through these lessons and these behavioral things, that we are shaping them as an adult. But in adults, this isn't just a phase. In kids, you know, you look at them, you say, oh, they're cute and cuddly. And an adult, you look at them and say, this is a person that I have looked at with dignity and respect for decades. and it's very difficult to see them in that place. And so the take-home message of this is that these types of behaviors are a function of the brain declining. They're not a choice. And if you can think back to some of these similar experiences of raising children, maybe you can see the parallels and know that you have the ability to navigate some of these frustrations. But sometimes you have to step back and see a little bit of the comical aspect and the fascination for life and the brain, both on the way up and on the way down.
And we thank you for that. I know I've heard from a lot of care partners and folks living with Parkinson's that humor is a big part of their day, that they just sometimes have to say, you know, we're in this together and there are things that, you know, we've got to find the humor in it. So I thank you for that. And Dr. Cyphers, we really appreciate you sharing your expertise today. As I said before, that there are questions that you submitted that were not answered today, please do get in touch with our helpline. And I'm going to pull up, I'm going to have Jen pull up a couple of slides now. We just, again, want to thank our silver sponsors today, AbbVie, Acadia, Accorda, Boston Scientific, Kyowa Kirin, Medtronic, and Synovian. Don't forget to visit them in the virtual exhibit hall after the program. And next, we do want to let you know we've got a number of upcoming programs that we'd love to see you at. Very related to today's topic, next week on Wednesday, March 3rd, we'll be hosting Thinking Changes in Parkinson's and the physical therapy role in it. That will happen at 12 p.m. Central Time, and you can sign up at parkinson.org/pdhealth. Then on April 7th, we will have a Parkinson's 101, What You and Your Family Should Know program. Encourage everyone to attend that and learn some of the basic information about symptoms and treatment. And then on May 1st, of course, join us for Moving Day Kansas City, as well as the remainder of our PD Health at Home programs that you can join every week. And lastly, I do want to remind everyone your feedback is vital to our future programs. Please do stay on for a moment after this to complete a short survey as we wrap up today. And we will also be sending out an email afterwards with resources and a recording of today's presentation, along with a link to that survey. This does conclude our program, and thanks again for joining us. Thank you, Dr. Cyphers. And everyone, please take care, stay well.